Good afternoon and welcome to today's edition of Black Health Trust. We appreciate that you took time out of your day to join us, and we trust you will enjoy this session. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Davis-Stevens, Dr. Ivan Walks, Dr. Hines, and Dr. Lawson. I'm going to need a lot of help today. My eyes are kind of not good today. But our topic today, we know there's so much going on in the world, with geopolitics and everything grabbing for our attention and being diverted. We often don't pay attention to things that happen to ourselves, and we minimize that cough or that blur in the vision or that pain here or something abnormal there. And it's been proven that sometimes when you ignore those things, they can result in greater harm. So we're going to show a few slides. We might not get to them all, but I need help from my co-hosts in doing this. Let's show the first slide, Simon. So hidden warning signs, what your body may be telling you. Next slide. So there's something called a persistent cough. And a cough that lasts 1 to 8 weeks, maybe even sooner, may signal lung or heart disease. It can also say that you're having something wrong with your gut. Next slide. Itching, which is also called pruritus. Chronic itching without rash might indicate liver problems, kidney problems, or even blood disorders. Next slide. So if you have changes in your bowel habits, persistent diarrhea or constipation, or stool changes might indicate gastrointestinal disease. Next slide. So cause of chronic cough. Dr. Neighbor-Stevens, do you want to take this one?
Certainly, the highest cause of cough, not surprisingly, is asthma. The second highest is gastroesophageal reflux disease, or GERD. The third highest is the other category, and the fourth highest is chronic bronchitis, another lung condition.
So what most people don't know that coughing can be gastrointestinal reflux disease. So it's not always the lung. Next slide. Dr. Walks?
Serious causes of itching. One primary cause. Oh, y'all are not able to hear me?
Not well.
Okay. Sorry. Can you hear me now? Any better? No. All right. Well, we'll let someone else go and I'll try to work on this.
So serious causes of itching. So serious causes of itching could be liver disease, kidney disease, thyroid disorders, or various cancers.
Next slide. Take this to that Neighbor-Stevens. That Lawson not on, is he?
Causes of bowel habit changes. Irritable bowel syndrome leads the pack, followed by diet and a tie between infection and cancer.
Next slide.
Colon cancer risk by age. 5% occur in the less than 50% age category. 20% occur in the 50 to 60-year-olds. 35% occur in the 60 to 70%, 60 to 70 year age range, and 40% occur at age 7 in this age group 70 and above.
Next slide. Dr. Walsh, you get your microphone working yet?
I don't know. Can you all hear me? Okay.
That's better. That's better.
That is
Take this.
that's fabulous and wonderful. Okay. Red flags. Weight loss, blood in the stool, coughing up blood, and severe fatigue. And are we going to get later to actually the color or the character of the blood in the stool, Dr. Maxey?
Yeah,
Because that can be different things.
we can talk about it now.
Well, I was just talking with someone earlier today about how folks will see red blood in the stool and just figure, oh, it must be hemorrhoids. I've had hemorrhoids before. And they don't pay attention to the fact that maybe they haven't had a colonoscopy ever, and they're already 70 years old. So blood in the stool is not just blood in the stool. It could be an indicator of something else. And then, of course, if the blood in the stool looks like it's coming all the way through the GI system, in other words, it looks like it's been digested, or it's dark and black as opposed to bright red. So I just want to make the point that blood in the stool isn't just blood in the stool, and always blood in the stool means you should be talking to your doc or your practitioner.
Okay, that's a very important point. And talking about if you cough up blood, let's talk about that a minute. Dr. Hines, you want to speak on that a minute?
Yeah, just a second to go back to blood in the stool. One of the smaller kind of tips, because again, blood in the stool is never something to ignore, right? One of the tips on how you think about blood in the stool, if it's on the toilet tissue or if it's just kind of coating the outside of the stool, then it's likely coming from the anal rectal area, right? Somewhere lower down. But if it's mixed in the stool, like if there's blood literally mixed in the stool, then it's usually coming from somewhere higher up. And I would also suggest that, the first, why am I looking in my stool, right? If you have blood in your stool, absolutely take the time before you, like when you've seen the tissue and you see that there's a problem, before you just flush, right? Because it's awkward. Go ahead and take the time to actually look and see what is going on. To your question about coughing up blood. So in the same way we could talk about how a cough can come from many sources, coughing up blood kind of has some similar things to consider. The first one is, how much blood are you coughing up? If it is more than a teaspoon, you don't need to be the person to investigate where it's coming from. That is a reason to go to the doctor or call your doctor's office, because it could be coming from your nose, it could be coming from your throat, it could be coming from your lungs, postnasal drip, GI bleeds. There's a whole lot of things, right? If your coffee ground emesis is a classic one, and for doctors, and that means you throw up blood that literally looks like coffee grounds. That is digested blood. That is a big giant problem. So again, some of these things are not very simple, but if something's wrong or abnormal and it's definitely more than just a smattering, then go get it checked out.
One of the biggest balling outs I got one time, I had a 80-plus-year-old lady who had some vaginal bleeding. And I said, well, she's 80-something years old, couldn't be much. And I didn't do a pelvic exam. And turns out, if you're postmenopausal and you start having blood again and say, oh, I'm just having a period again, that's a dangerous sign. Major problem with that. Anybody want to comment on that?
So for if you have stopped having bleeding for a year, right? And that year matters because when you're perimenopausal, you could skip 2 months, you could skip 11 months, right? All of those things in between. But if it's been a year or more since you've had vaginal bleeding, a full-on period, spotting, any of the irregularities that come in that perimenopausal period, and then it comes again, that is worth getting a pelvic examination for, because it could be something like uterine cancer. That's the first thing that we're going to want to rule out is uterine cancer. And then after we rule out super bad things, then we can look at more benign things, like sometimes vaginal dryness and stuff like that can lead to some bleeding, and it's not actually a period. It is bleeding from a different reason. So all of these things have some things in common, which is just because you see blood, that doesn't necessarily always tell you where it's coming from, and you may need help to figure out where it's coming from, and that's what your doctor's for.
And the last point is the severe fatigue. It's not always just because you're getting old or because you work too hard. It can be that you have a lack of blood, and that can lead to fatigue. So you need to have that checked out as well. Let's go to the next slide. That's Neighbor Stevens.
Take action. Do not ignore persistent symptoms. Seek medical care early. Screening saves lives.
Next slide. You want to do this one? Next slide.
It's coming. Oh, maybe that's the end.
No.
That is the end of the slideshow that I have.
Wow. I had 50 slides. But
I
well,
got 10. The version I got has 10.
okay, let's do it one more time.
So Dr. Maxey, while you're working on the slides, let me just go back to what we were just observing. We dropped screening in there, and I think it's important for folks to always distinguish between routine screening and responding to something that is worrisome. So we've been talking to this point about things that may pop up that are worrisome. And so even if you have been getting your regular screening, even if you've had your annual visit to your practitioner, when the things we've been talking about so far come up, it's time to call and make another appointment, right? So if I went to my doc and everything was fine, but then over the last month or so, I've had this persistent cough. It's time for a follow-up appointment. Or I went to my doc and I went to my practitioner. I had my regular follow-up, but then now I've got this. I'm coughing up this blood, or I've got this. As Dr. Hines was saying, I've investigated my stool to the extent that I can. I've looked at the tissue. I've looked in the toilet, and I'm seeing that there's blood in there. It's not time to wait until your next exam because it may not hurt. There may be blood coming that's not hurting, and you are making an assumption that, oh, I already had my checkup. So routine screening, annual checkups is not really all we're talking about today. Today we're talking about things that may pop up.
I think that's a really good point because I've seen that a lot, right? Where people said, "Oh, but I got my colonoscopy and they said I didn't need to go for another 5 years." Yeah, that was before this issue showed up, right? So oftentimes what people can sometimes forget is when you left your doctor's office, right? And you all set a follow-up plan that was based on the information that was available at the time, right? When you have new information, then we need to respond to that like it's new information. So if you had a 3-month follow up and it's still 2 months away, then that's a reason to call and schedule another appointment, not necessarily just wait until, oh, but I have an appointment in 3 months. I'll just ask about it then. Because to be honest with you, that 3-month appointment was to talk about the stuff that was there 3 months ago. It wasn't even meant for the new thing that has happened. So sometimes it's a really good point about the place for maintaining your scheduled appointments for when things are going fine, but also being willing to be flexible and adjust when something new has happened, and respond to that accordingly.
Okay, I sent those slides, Simon.
And let me just add, probably in the slides that we haven't gotten to are probably at least a few slides about my head isn't right. That's the category that I'll say. Anytime you feel a little bit dizzy or you feel a little bit lightheaded or anything like that, that's not ordinary. It's not ordinary for you to feel dizzy or lightheaded. So I will stand down while we get back to the slides.
Okay, Simon, you get a new set. Simon, you get new slides? I sent everybody new slides. Go
This is
ahead.
the new deck. This is the new deck.
Yeah, next slide. Okay. Go ahead.
So we're back to the beginning. No? Okay.
So we know that patients sometimes have a busy life. They assume that whatever's happening is benign and they fear a diagnosis. They're scared to get diagnosed. Next slide. We talked about fatigue. Let's go to the next one. Fatigue causes could be anemia, heart disease, kidney disease, thyroid. Next slide.
What about inadequate sleep?
Of course, that
That
can-
one.
You know, that one can, before we just kind of move through that one I think trips people up a lot, right? Because for all the other things that can contribute to fatigue, including out of shape, right? And the number of people who think, you know, we glossed over it like that it's just because I'm getting older. And I'll be honest, I don't have any real good anecdotes to tell the difference between, to help people tell the difference between out of shape and yeah, that's an abnormal amount of fatigue, shortness of breath for just walking down the driveway or that type of thing. So, and again, I think it just might have to come. You don't have to solve every problem or know the answer to every problem at home, but don't just assume that everything is just a normal part of aging or those types of things. So it could be any of these other things going on. And obviously, if you could fix them, you would. So that's another reason to go get help.
So this suggests that some of these things you need a CBC, a blood count, a comprehensive metabolic panel. It might be a thyroid. You want to get that checked. You might want to have a cardiac evaluation as well. Next slide. Those are
Or
good.
sleep apnea?
Or sleep apnea.
Big cause.
So I had a call from one of my relatives yesterday about having cramps. Want to take this, that's neighbor receiving this and several slides after this one.
So we're going to give an overview on cramps. Cramps, muscle cramps may signal there's a disease or a problem cooking.
Take the next slide.
Causes of cramps can include things like your electrolytes not being in normal range, that you've got some peripheral artery disease, or you have some chronic kidney disease.
Next slide. You want to talk about this more, Dr. Hand?
Sure. Some of the red flags in that space could be pain with walking or cramping pain with walking. That's pretty classic for peripheral artery disease. Like if you get bad muscle cramps early on with walking and then they go away when they stop walking, that can be a real red flag for some blood flow issues, right? Night cramps are another potential red flag. They're extra common in electrolyte issues too. So just, again, the more details you can give your doctor about the patterns that you see, what makes it better, what makes it worse, where it hurts, like cramping in your thighs and upper parts of your leg versus cramping in your calf are going to signal different things. So the more details you can share, the better.
Next slide. Dr. Walks. Next two slides.
Headache overview. Headaches are common, but sometimes can indicate something dangerous is going on. Yes.
Next slide, Simon. Yeah, go ahead. Go, Dr. Walks.
Okay. Headache, red flags. If your headache is sudden and severe, that's a red flag. A sudden severe headache is not a good thing. And then if your headache accompanies neurological deficits, if suddenly you can't move something or you can't feel something and it came with a headache, absolutely it's time to get some help with that.
So Dr. Walks, I had a niece who had a super bad headache posterior around C6, C7, and turns out she had a dissected aneurysm in a vertebral
Hmm.
artery.
Hmm.
That was scary for a minute, very much so. And it turns out she only had one open vertebral artery, so it was going to be a
So
problem.
so Dr. Maxey, before you go on, see, Dr. Maxey has MDs and PhDs, and I talk to regular folks. So you had a niece that had a really bad pain really high up in the back of her neck, and there's a big artery that runs through that area, carrying blood to the brain, and inside of it, it started coming apart. Is that what you were saying?
Exactly. There are two
Okay,
arteries.
so
There's a left and a right vertebral artery. They supply the brain.
So let me stay there for a minute, Dr. Maxey, because it's important for us to understand that things like arteries beginning to come apart, things like strokes and all of that, don't just happen to people when they're older. I had a cousin that had a stroke and died when she was 31.
Mm.
Didn't have any other health issues, but had a major stroke and died at age 31. So we're not just talking to people that are of a certain age. When we say red flags, these are things that should be investigated right away.
And the takeaway from that, what she had when we got the history, she had her neck and back adjusted by a chiropractor. And we think
Mm.
that could have been the pathophysiology of what happened. Next slide.
Can I just add a couple other headache red flags
Yeah,
to your list? If you are over 50 and you've gotten new onset of kind of recurring headaches, that is off, especially if it's kind of in your scalp or jawline, that is another common indication to get that checked out. And then headache with, bad headaches with fever or other systemic illness are also um, red flags, as well as positional or exertional headaches. If I get a headache when I exert myself, yeah, that's a problem. Um, so I just wanted to, there's a few others that are kind of common that I wanted to add to your list.
So Dr. Hines, that's different than if you just don't want to work out and you say you have a headache every time you work out.
So very, very much so, because for the majority of us, right, when we work out, the thing that is making us stop is usually our cardiorespiratory tolerance, right? I'm out of breath, right? I'm short of my heart rate's going too fast, or sometimes my muscles give out. Like there's very few people that say, why did you have to stop exercising? Oh, because my head started hurting real bad. Like that is not usually the number one reason people stop exercising, right? So that is something that should be a signal to you that, hey, something's off.
there's social implications to headaches, but we won't go into that too.
Well, there's that. And who you walking with, right? Like who you exercising with, right?
That's neighbors even on this one.
Signs of stroke. These are things that we really want you to keep in the back of your mind in case you yourself or someone you're with starts to experience these. One side or the other of the face seems to be drooping. The extreme outer end of your mouth and lip is going down, and it's not equal to the other side. There's either one side or both sides, arm weakness. And there can be problems with speech. Now, speech difficulty can be because the mouth won't work to form the words, or it can be that the words don't come to the brain
Hmm.
as a thought so that you can speak it. Either one, though, is something
Yeah,
that you should pay a lot of attention to.
yeah.
And there's something else, not normal sign. Sometimes you can't open a jar or take a top off. And it could just be weakness, but it could also represent a stroke. If you can't take the top off that jelly. Next line. Dr. Walks?
Shortness of breath overview. Shortness of breath is a key cardiopulmonary symptom. Means something may be going on with your heart or your lungs and that whole system when you're short of breath.
Take the next slide after that. I think it goes further.
Shortness of breath causes congestive heart failure, pulmonary embolism, or asthma.
Next
And
slide.
pulmonary embolism, that Dr. Maxey, as you jet setting across the country back and forth, you got to remember to get up and walk up and down the aisle from first class back to where I'm sitting. You got to keep doing that, right?
I get seat number 37 back by the bathroom.
Well, let me just make it a little more to a more common situation. If you've been sitting there watching TV for 3 or 4 hours and haven't gotten up, that's another setup.
Okay. And it's also good if you're on that plane to wear some hose that make your circulation better in your legs too. Go ahead with this one, the red flags. Go back. Yeah. Who was on? Dr. Walsh, finish this one.
So shortness of breath, red flags. If you're not doing anything and you suddenly get short of breath, that's a red flag. It's not, well, I got up and I lifted something heavy and I got short of breath. No, if you are at rest and you get short of breath, that's a red flag. Or if you're short of breath going up the stairs, but it seems to be getting worse and worse. Every time I try to go up the stairs, I'm getting more and more short of breath. So worsening, just about anything that is uncomfortable, that is getting worse, you should have it checked out.
Can I just add to, if you can't speak in a complete sentence without needing to breathe, that is short of breath. Because I think sometimes people have a hard time figuring out what short of breath means, or what it looks like if they're still able to manage. But if you can't talk without feeling like it makes you winded, yeah, that's short of breath.
Very good point. Next slide. So if you have chest discomfort, it's not always a pain, just discomfort. Next slide. So it could be coronary artery disease, CAD, could be GERD, gastroesophageal reflux disease. It could be musculoskeletal. It doesn't have to be on the left arm, left side. It can be in your jaw. It can be referred. It can be in your stomach. It's not specific where it can be, but it can be related to your heart or something else. So pay attention to it. It could be one of those three things. And musculoskeletal, sometimes you get the little muscles in between your ribs get inflamed. And if you press on it, it can hurt. So one of the blood tests they may do for you if you go to emergency room or urgent care is something called troponin, which is an enzyme which goes up if you have damage to the muscle of your heart in a heart attack. Let's go to the next slide.
So,
Can I just
so
add in
be,
that chest space, as we've now entered spring, right? And it's a lovely time for golfing and those kinds of recreational sports. So if you're on the golf course, right, and you find that when you're out playing golf, when you get on that back nine, you feel like there's a little bit of discomfort in your chest, right? That is what we're talking about, right? That's the kind of that kind of stuff that then slows you down, makes you pause, take a break, go ahead and let the next guy go. Those are the red flags that we're talking about. It's not just the dramatic stuff that you see on TV, right? It is not necessarily the, Red Fox version of what's going on. That's how it shows up. For lots of people, it is subtle first before it's dramatic.
And especially if you're shooting about 150 strokes. By the way, Tiger had another crash yesterday. Tiger Woods.
yeah,
Go
well,
ahead, just Dr. Hines.
Other chest red flags. So radiation, that means that discomfort, right? Because we're not going to use pain because a lot of people refuse to say that they have any pain, right? So that discomfort is it could be moving into your shoulder. It could be moving it could be in your tooth, right? If I'm on the golf course and I keep getting this weird dental pain, this weird tooth pain when I'm on the golf course. Yeah, that is coming from your heart, my friend, right? Even on the side of your neck, all these other places where that kind can show up, like it can show up as fatigue, like, oh, this arm gets so tired, right? For no good reason. It's just so tired over there. That's called radiating pain, radiating discomfort, and then sweating. If you are sweating profusely and it is not normal and you're the only one and it is not a personal summer, that is a red flag, right? If that's not normal for you, and then it's only 60 degrees, but there's just sweat pouring down your face, those are red flags that you have to respond to. Don't let the embarrassment, the shame, all of those kinds of things. Ooh, my weight must be all the things that we tell ourselves because we don't want anything to be wrong. Those are the things that you have to respond to.
Excellent.
So let me just add that um, women talk about getting a personal summer as they get a little bit less young. Um, I heard a rumor that can happen to men too. They can have. We, don't laugh at me, Dr. Hines. So what it means is that you just need to get it checked out. You need to make sure that it is something that is part of your ongoing development. You can laugh at me, Dr. Hines. That's okay. But
It's not it's not
it's
it's
not
not
funny. Yes, it
actually
is.
so the reality is yes, right? One of the things that I think is great about the benefits of like social media and the things like that that are coming to the forefront of people's conversation are some of these things that people experience that they have been thinking that maybe they're the only ones. So yes, men can get hot flashes, is obviously significantly less common. But to your point, it is always something that is worth evaluating. And the short answer as to why they could get them is because men are having hormonal changes, and changes in your testosterone levels and those kinds of things happen to you all as well. So, and your body responds. That's the short version. But again, when you're on the less common side of any kind of symptom, that's a reason to go get it checked out and then let somebody else verify that, okay, you get to be an individual and then carry on.
And if I have one more patient explain to me how it's so hard to bring something up because it's embarrassing, I think I'll just scream because all of us, doctors, non-doctors, whoever you are, we all have to have that trusted practitioner that we can tell anything to, anything. You know how hard it is to tell somebody that you've been looking at your stool and you found some blood in there? That's not an easy thing to tell a stranger. So having a primary care person that you see that you can call, it may be hard to find, but it's just important to have someone that you can talk to about whatever is going on that is not ordinary for you or has just started happening for you.
Very good. Let's go next slide. So that's neighbor Stevens, next two.
Vision changes, blurred vision or loss of vision, or changes like
Yes.
the spots. All of a sudden, you see a black spot going past, or when you hold your head up, this black spot moves, and you hadn't had that yesterday. Um, those are signs that need to get checked out.
Yeah, take next slide.
Can we stop here for just a minute, Dr. Maxey?
Yes.
This is for those of us who have been really afraid since the age of 7 that we may not be able to see well because that's when we got our first pair of glasses. The whole vision changes thing is really a big deal because I had a detached vitreous where suddenly like a curtain fell in the back of my eye. It is terrifying. And we have got to be able to recognize that things can happen that are different. I tried to do the fasting with the young people at church one time, and suddenly my vision got better. I was like, what? My vision's getting better. I'm aging backwards. No, it was because anyway, anybody who has diabetes will understand that sometimes when you decide you're going to do what the young people do, your body will give you a signal. Dr. Neighbor Stevens, it can happen. It can happen. But a good friend of mine who was a doctor said, man, you're trying to kill yourself. And I said, no, I'm not. So anything that's a significant change in your daily routine, mention it to somebody. Don't just say, well, I'm gonna just go to bed and it's gonna be better tomorrow. Maybe not.
That's
Can I
just
also just add to the insidious, the slow onset of the vision changes? The acute vision changes, I would imagine, are more noticeable. But those slow ones that are often cataract related, right? They're happening over time and people start adjusting to them without realizing it. I had a patient who came into the ER one time, and her complaint was sudden vision loss. And I am all in a tizzy, right? Both, right? Both eyes. So I think she was already, anyway, it was a whole thing. And come to find out, the lady actually had cataracts and had had cataracts for a long time. And it had just finally gotten to the place where that cataract had taken away what little bit of vision that she had left. And in her mind, it felt all of a sudden, because all of a sudden there was nothing, but things had been changing for her gradually, and she had been adapting to those. So just try it. It is hard to take notice for all of us for any number of things. That's how you gain 30 pounds and you didn't even realize it, right? Because it happened over time. To say when things are happening gradually, it can be harder to notice, but we do have to continually pay attention. And that is also the place where, you know, those screening tests and routine checkups can help you catch things that may not have even made it to your radar. But especially in the place of vision, a lot of people are having, especially with the chronic diseases, you're having slow changes that can have permanent impacts.
Dr. Neighbor-Stevens, take the next slide, please.
Causes of vision changes. You know, I'm pausing because it seems like we always come back to these, but blood goes everywhere and it causes these kinds of issues. So you can have changes in your vision due to interruption of the blood flow to the eye. Diabetes can do the same thing. And retinal issues, retinal and vitreal issues, such as Dr. Walks just described. And just to tag on to what you said, Dr. Walks, about the need for, that we've all been saying, the need for checkups, including your
Yeah.
eyes. There's an increased incidence of glaucoma in African Americans,
Yeah.
and that's a very good reason to, and if you have a family history, doubly so, to get frequent checkups. But I found out something that, and that's always good to learn something new. I'm one of those kids like you, Dr. Walks, that needed to start wearing glasses when she was 5, but it wasn't picked up until I was 10. And I and am still very nearsighted. Well, when you have chronic nearsightedness and put a little astigmatism on it as the icing on the cake,
Yeah.
you can have increased issues in the back of your eye involving the retina and the vitreous because of the changes over time. Now, when we say over time, we're talking about a lifetime. To the back of the eye, which can lead to some of these detachments and very sudden onset of changes that you don't hear people talking about.
Right.
So something I want
And that's
to,
why I'm bringing it up, because that is another
Yes.
really common thing.
so one of the things I want to warn people about, a lot of people say they've gone to the eye doctor. They didn't. They went to an optometrist or an optician. A real eye doctor is an ophthalmologist. They're a physician, and they have the ability to look into your eye with machines that look at your retina all around. They measure the pressure, and it's a much more thorough thing. It may not just be glasses they can prescribe. So when you have vision problems, you need to see an eye physician called an ophthalmologist, not an optician. Next slide. We'll go to Dr. Walks.
Hearing changes. If you have a sudden hearing loss, that is an emergency.
And the next
Somebody
slide,
needs to do something right away.
the next slide is a follow up on that. Take this.
Dizziness overview, common but concerning. I don't know, Dr. Maxey. I don't think dizziness should be common. I think it may be common, but if you are dizzy, I don't like being dizzy. I don't like it at all.
Advance the slide, Sam, if you would. Go ahead, Dr. Walks.
Okay. Dizziness causes arrhythmia. We talked about Your heart is so important for all of these little hints it gives you that something is wrong. So if your heart rhythm is not right, that can be a cause. And then orthostatic hypotension. So my blood pressure is okay, but then when I suddenly change my orientation to the world, I stand up and I get dizzy. That's not good. That's not normal. That's not ordinary. So this sort of change, dropping in your blood pressure when you stand up, if you get dizzy, again, not a good thing.
Okay, let's
So
give
did we put maybe one of the most common causes on here? Dehydration. Are we going to get to that?
yes, we
Because
will.
everybody's trying to be fit now. We're trying to go and
I don't think we're going to be able to finish this date, but let's go as fast as we can and try to get
okay.
a few more slides in for you in an hour. Dr. Neighbor Stevens again.
Swelling overview. If you observe swelling in your, well, anywhere, but where it usually shows up is either in your feet or legs, your hands, or in your face, that can be a sign that you have what we mentioned earlier, congestive heart failure, which is a result of retention of fluid in the bloodstream. And so it goes out into the tissues.
Advance the slide.
Causes include heart issues, kidney issues, and liver issues.
Next slide. Weight loss. Go to the next slide. If it's unintentional, that's a red flag. And we know this could be cancer, it could be other chronic diseases that do that. Next slide. Urinary changes. If you have foam or blood in urine, that's something that you need to look at very seriously. Foam usually means you have protein in your urine. Blood in urine, you have kidney cancer, and a number of other issues. Go to the next slide.
Yeah.
The warning signs such as proteinuria, which makes foam, or blood in the urine, which can mean kidney stones, can mean kidney cancer, a number of things, but don't pass it off. Next slide. You want to take this, Dr. Walker? And we're trying to go fast to get a few more slides in.
Anemia overview. Low hemoglobin is anemia.
Next slide.
We went past one, but okay. Anemia symptoms, fatigue or shortness of breath.
Next slide. Dr. Hines.
Emergency symptoms related to that are going to look like chest pain and stroke symptoms.
Okay. I think they're going to start repeating. We're at the top of the hour. Why don't we just have a brief discussion over some of the things we talked about? We got about 4 or 5 more minutes. Dr. Hines?
So I think this was a robust discussion, and we covered a lot of things. And I think the thing I would just take home is that you don't have to answer all of these questions alone, right? A lot of these things were nuanced, and the difference between something that is an actual emergency or a serious illness and something that we can, is a fixable thing. We just need to address it. You don't have to answer all those things. You don't have to let Dr. Google or ChatGPT answer all of those things. Having a provider that you can be honest with about what's going on is critical to helping you navigate those situations. And if you have a provider that you feel like you can't tell them what's actually going on, you might want to question that relationship. And you also, too, might have to look at yourself, too, because the other thing is we're doctors or nurse practitioners or whatever your PCP is. This is the stuff we train on, the stuff that grosses out strangers and the other people in your family. Well, they're supposed to be, grossed out, but not us, right? That's not the same reaction that you should expect from your provider, because that's the space that you deal in. So give them a shot with your honesty and the details of what's going on, and let them respond. And then from there, you can see if that's somebody you can stick with.
And Dr. Walsh, I want you to comment on, if you would. We know we're diverted oftentimes with everything that's going on with this administration. You got war in Iran, war in Israel, war in every place, and we don't pay attention to ourselves. Can you comment how this distraction affects us and how we can best avoid it?
I think, Dr. Maxey, anytime you've got thousands of events and millions of people around the country protesting it is something happening in our country. And I think that all of the slides that we went through today, we can put a mental health twist on there. We can put either because of something happening with our mental health, we either aren't noticing something that's going on. We're chalking it up to stress. Oh, I'm just stressed. I'll be okay. So I think that I had a patient say, Dr. Wilkes, I feel like the whole world is on fire. And my response was, well, I think it is. I mean, I think we can look all over the place and we can find that people are hurting other people. And there's always a reason that people have to hurt other people, but it's uncomfortable for most of us to know that people are being hurt someplace. So right now we are in the middle of a very challenging time on our planet and a very divisive and divided time in our country. And so everything we talked about today, we can just sprinkle some mental health challenges on top of all of it because mental health challenges will make all of it worse and at the same time make it harder for us to reach out for help. So big stuff going on right now.
Thank you. That's Neighbor Stevens.
Well, I think the takeaway message for today is if you, as they say about crime and stuff, if you see something, say something. I would say if you see something, get it checked out. Don't make assumptions. It's great if it's not something serious. It's even better if you went and it is something serious and maybe you're there and somebody can do something about it. But doing nothing is not the right choice.
Excellent. Do we have anything in the chat to answer or address real quick?
We
No.
had something in the chat about what a great discussion this was and how we should maybe consider continuing the discussion next week. And I think that sometimes when we get into these practical, what can we do and what should we do, I think that's pretty useful for folks.
Excellent, excellent. I thank everybody for joining us. Next week is Easter Sunday, I think, right?
Yes, sir.
And that's important to a lot of us who believe in Christianity. It's the ultimate holiday we have, but we'll be here. Thank you, everybody, for joining us this afternoon. Thank you, Simon, for your help, and thanks for dealing with my slides and my inability to get them emailed on time. Thanks, everybody. Have a great day.
Happy Palm Sunday, everyone.